Hello and welcome to tonight's webinar on wound care management in general practice. And I'd like to introduce Sara, who is a registered nurse. She's worked in wound management for the past 15 years. She completed her nursing training in Sydney and at Royal North Shore Hospital. And since then, she's been working at various hospitals and aged care facilities around Sydney. Sara joined Hartman in 2010 and as a national clinical educator for wound management. This role includes both internal and external education in wound management, as well as providing the sales team with clinical information and evidence to support the use of Hartman products. She's also completed a Certificate 4 in Training and Assessment in 2009 at Hornsby TAFE and upgraded it in 2014. And I'll now hand over to Sara. Thank you, Sara.
Good evening, and thanks very much, Judy. As Judy mentioned in her introduction, one of the benefits of the health pathways for the PHN is to avoid hospital admissions where possible. By having a better understanding of wound management to improve healing outcomes for your patients, you have a much better chance of achieving this and reduce the need for hospital admissions. This is the first in a series of 4 educational webinars, which I hope will provide you with information on how to prevent, assess and treat the wounds you are seeing in your practice or facility. Before joining Hartman in 2010, I worked as a registered nurse in both public and private hospitals, as well as residential aged care. I've always had a passion for wound management and feel as though it's often a forgotten area of training when it comes to medicine and nursing. This makes it extremely difficult for both doctors and nurses to know how to best manage wounds, especially chronic wounds. In addition, there are so many different products on the market these days to treat wounds that it can be extremely confusing to know what the right dressing is for the many different wounds you may be dealing with. Always remember that it's the body that heals the wound, but it's up to the care provider to create the right environment for the body to heal. My aim for this series is to help you to understand what you're looking at and how to address the needs of the wound to create that healing environment. Topics to be covered tonight are looking at the skin, wound healing, and the factors that impact on healing. We'll look at assessment and the importance of good documentation. We'll take a quick look at burns first aid and the management of minor burns. And finally, we'll look at skin tears and how to prevent and treat them. At the end of the session, we'll have a quick fun quiz. So before we start, I'd like you to take a couple of minutes to download Kahoot, which is an app that you can get from your app store on your iPhone or on your Android if you have an Android. You'll need this to play the quiz. So I'll give you a couple of minutes to do this. You just need to go into the App Store and look up Kahoot, and you'll see a little symbol like the symbol that I've got up here on the screen. And you just download that Kahoot app onto your phone, and that'll help later on in the presentation. And it'll be worth it because first prize is a $50 gift voucher and a sample flip chart. Second prize will be a $30 gift voucher and a flip chart, and third prize is a $20 gift voucher. So it's worth your while taking a minute just to download the Kahoot. Okay. So, who is Hartman, I hear you asking? Hartman is a global company with over 10,000 employees. It's been around for just on 200 years and started in Germany in Heidenheim in 1818. Our headquarters is still there today. In Australia, we have a continence and skincare portfolio the Molicare range, as well as an excellent wound care portfolio with products such as Zechavit Plus and Atrauman that you may be familiar with. Before we start, I just wanted to give you a quick snapshot of the impact of chronic wounds in Australia. I know tonight our focus is on acute wounds, but I still think that when we look at wounds, we should keep these numbers in mind, as most chronic wounds start as acute wounds that just don't heal.
How can I?
Did you know that there are more than 433,000 Australians affected by chronic wounds, which is costing the health system more than $3 billion annually? It's a major clinical challenge, with more and more people developing diabetes. Major amputations are increasing to over 4,000 a year. Chronic wounds reduce the quality of life for patients and in turn their working capacity, which leads to an increase in social isolation, as they often take months or even years to heal. They are a hidden problem that are not discussed enough, and the more that we can do to increase awareness and improve healing outcomes, the better for the people who are struggling with them. All right, so now before we go any further, let's take a quick look at the skin. The skin is the largest organ of the body and is made up of 3 layers: the epidermis, the outermost layer; the dermis, also known as the factory of the skin, as it contains so many of the structures that help the skin to function; and the subcutaneous layer, which can also be referred to as the adipose layer or the hypodermis. The epidermis is the top layer, and we're going to take a closer look at that. The epidermis consists of a series of layered cells known as keratinocytes, which replicate in the basal or bottom layer and gradually migrate upwards to the stratum corneum or the top layer. As they progress through the layers, they gradually die off and become thinner and harder to create a protective barrier to bacteria and other damaging substances that we come in contact with in our daily lives. Then, when they reach the stratum corneum, they shed off on our clothes and towels and bed sheets, and this process takes between 15 and 30 days. And of course, it slows down as we age. There's no blood supply in the epidermis, so the basal cells absorb oxygen and nutrition from the capillaries in the dermis by diffusion through the epidermal-dermal junction. Also found in the epidermis are melanocytes, which produce melanin, which is stored by the melanosomes and is responsible for skin colour and UV protection. Keratin is a protein that gives the skin its strength and structure, ensuring the keratinocytes adhere together to form a waterproof coating. The dermis. Within the dermis are a number of structures which allow the skin to function effectively. It's about 2 to 4 millimetres thick, depending on the location on the body, and is thickest on the back. Let's take it from the top here. The sebaceous glands produce sebum, which makes up part of the acid mantle on the surface of the skin, creating a protective barrier to toxins such as urine and faeces. The erector pili muscle is responsible for the formation of goosebumps to keep us warm. The sweat glands allow for the elimination of waste and cool us down. Capillaries provide oxygen and nutrients to the cells in the dermis and epidermis, as well as providing a reservoir of blood should we need it in a flight or fight situation, which is why we go so pale when we get a shock. The hair follicles help with temperature control and, of course, cosmesis. The dermis is filled with many sensory receptors, enabling us to feel sensations such as rough surfaces, hot, cold, and pain, again helping to protect us from damage. Vitamin D is also synthesized from the sun through the dermis. It's converted into calcitriol in our kidneys and gives us bone strength. We often rely on the change in the colour of our skin for communication. For example, when we're angry or embarrassed, we go red, and if we're sick or in shock, we become very pale. The subcutaneous layer is our protective barrier from the deeper organs. It insulates our body and provides us with a support framework for the skin and acts as a protective coating for our underlying organs. So, as you can see, the skin is quite a complex organ. It provides protection from the challenges of the outside world while helping us keep our body nourished and protected. I think of it as a bit like an eggshell. As health professionals, we need to play a pivotal role in the prevention of breaks in the skin and the maintenance of skin integrity. The last thing the sick or elderly are thinking about is caring for their skin when they come into hospital or are in residential aged care. Therefore, it's up to us to take responsibility for its care and treatment and to protect it from any damage. It's important to understand the stages of wound healing in a healthy person to know when things aren't progressing as they should be. This will be very quick, I promise. There are 4 stages in the wound healing process. All wounds need to progress through these stages to heal. The severity of the break in the skin and the condition of the patient will affect the time it takes to progress through the stages, particularly in the inflammatory stage where many chronic wounds become stuck. Hemostasis is essential to control bleeding. Bleeding is stopped by a spasm of arteries and capillaries around the injury. Platelets build up on torn collagen fibres at the end of the injured vessels. They release chemicals which attract more platelets and fibrin to the wound and cause a further spasm of the vessel. This is how a clot is formed. Of course, some medications such as warfarin and aspirin inhibit hemostasis. So when taking a history, it's essential to understand what medications the patients are taking. The inflammatory stage. Think about the last time you injured yourself. It's usually more painful the day after the injury, and if you look at the wound, it's often quite red and angry. No, it isn't infected. It's just the normal inflammatory process at work, and within 24 to 48 hours, it should have all settled down and be well on the way to recovery. If it isn't, then you can start worrying about infection. During this stage, cells such as neutrophils, macrophages, and growth factors flood the area to kill the bacteria and clear the debris and promote the growth of new tissue. I'm just going to go back. Sorry, I went a bit fast. In normal wound healing, neutrophils release protein digesting enzymes called matrix metalloproteases into the wound bed to clear up the debris and promote the growth of new tissue. They play an important part in the wound healing process, but they are also responsible for slowing the process in chronic wounds. We'll talk more about that next week. There is a lack of oxygen in the area due to the reduced blood supply resulting from the trauma of the injury. This causes a release of chemicals which encourages the blood vessels in the surrounding tissue to dilate and bring more blood to the area, giving this its reddened appearance. The proliferative stage. This is a stage of growth and regeneration. We're growing new tissue and repairing the damage. Fibroblasts promote the synthesis or production of collagen and elastin to give the wound strength and elasticity. New blood vessels grow in through the new granulation tissue to repair the deficit. New nerves and collagen fibres also grow into the tissue. Collagen fibres are initially laid down in a tangled and disorganised manner, and as the wound progresses through healing to maturation, they become more organised and linear. This also gives the wound its strength. Muscular cells called myofibroblasts pull the wound edges together. Once the granulation tissue has filled the deficit, the keratinocytes migrate across this tissue to close the wound. Maturation. The wound is healed and covered with a layer of keratinocytes, which will migrate and thicken as the wound matures. The tensile strength of the wound is increased by the changes in the collagen fibres as they knit together. They're now structured and organised into a linear fashion across the wound bed. The wound, however, will only ever regain 80% of its tensile strength. This is important to consider when assessing a patient or resident. If they have an old wound, the strength of the area will be less due to the damage caused by the previous injury. There's also a decrease in the redness of the damaged area due to a reduction in the vascularity of the wound bed as the vessels reduce to normal size and the wound gradually becomes more similar to the surrounding skin. This now completes the stages of healing in a healthy person who has no underlying issues, preventing the progress of the wound to repair and restore skin integrity. In the next sessions, we'll look at the impact of poor health and other contributing factors that have on healing. The most critical part of good wound management is wound assessment. There's an old saying amongst woundies, always look at the whole person before looking at the hole in the person. It's highlighting the importance of conducting a holistic assessment first to identify factors that can impact on healing and then assessing the wound itself. Understanding what health conditions may be contributing to their wound not healing is essential. Some of these factors include age, comorbidities such as diabetes and peripheral vascular disease, poor nutrition and hydration, obesity, pain, depression and mental health conditions, poor mobility, a loss of sensation, chemotherapy or radiation therapy, and finally, of course, medications, such as corticosteroids, which inhibit the inflammatory response, or nicotine, which is a vasoconstrictor and diminishes red blood cells, and of course, anticoagulants, which reduce their ability to clot. Then there are the local factors that impact healing. Foreign bodies, including dead tissue, bacteria, dressing materials or environmental debris such as glass, dirt or hair, can all be taken as a foreign body by the body and rejected, causing inflammation and then infection. Bacteria in excess will stop the wound from progressing, and if allowed to stay there for too long, can form a biofilm or colony which is resistant to antibiotics and antimicrobials. Wound temperature, in particular, letting the wound cool down by washing it in cold saline, which will cause the blood vessels to constrict and in turn slow healing. Try and ensure any fluid being used on the wound is at body temperature. In chronic wounds, an increase in pH due to the increase of toxic exudate, which tends to be alkaline, can allow for an increase in bacterial growth and slow healing. Poor wound management practices, such as constant dressing changes or inappropriate dressing selection, or a lack of education, can have an impact on healing as well. I've just selected this image as an example of a disaster, a poor management practice, which would be everyone's nightmare. But it's really important to remember that all the processes and procedures need to be followed and appropriate product selection needs to be made, and they need to be given a good chance to do their job. I think there's a 14-day rule with a product to ensure that it's doing its job and not causing and not changing it every couple of days to a different type of product. Give the products a chance. Pressure, shear and friction on the surface of the wound leads to further skin and tissue breakdown. Assessment and documentation. It can make such a difference to care for a patient or resident when the assessment is done well. It's essential to understand what the wound needs are prior to selecting the dressing, so you can match the dressing to the needs you've identified in your assessment. Here's an example of a good assessment and a bad one. Wound description A. Skin tear on the left arm with some loose skin on the surface. Tells me nothing really about the wound itself. So when the next person comes to look at the wound, they don't know whether it's improved or deteriorated. Wound description B, category 2B skin tear on the left lateral aspect of the forearm. Skin flaps bluish and queried non-viable. Surrounding skin looks dry and delicate, but not red. No bleeding or sloughy tissue seen on the surface of the wound, and it looks clean and granulating. This categorises the skin tear to provide a consistent descriptor based on the established categorisation system, in this case, the STAR categorisation system. It details the colour of the flap, the condition of the surrounding skin, and describes what is seen on the surface of the wound. This can make such a difference for the next person coming along to look at the notes, understand what the previous person has seen when they've changed the dressing, and then they, of course, can understand whether the wound has deteriorated or improved when they look at it. The triangle of wound assessment. This, in 2016, the World Union of Wound Healing Societies developed a position document looking at wound assessment. They broke the wound up into 3 distinct sections: the wound bed, the wound edge, and the peri-wound skin. Each of these areas are significant and important to wound healing. By doing this, it encourages clinicians to identify barriers to healing in each section and develop a management plan to address these issues. This is particularly helpful for chronic wounds, but can also be used for acute wounds as well. Here's an example of a wound. We'll break it up into 3 separate categories: the wound bed, the wound edge, and the peri-wound skin. Does anybody want to turn on their microphone and describe what they see on the wound bed? I've outlined the wound bed here. A shallow wound, fluffy tissue present across the centre of the wound. Appears to be heavily exuding. Hypergranulation seen in the centre of the distal end of the wound. Irregular margins, granulation tissue present on the proximal end of the wound. That was my description of it. Now let's look at the wound edge. Erythema present on the proximal edge nearest to the nearest point to the torso, in case anyone was wondering which was the proximal edge. Some maceration present at the lower edge or distal edge of the wound. Appearance of the ridging or trauma from bandage across the distal edge of the wound. And then finally, we look at the peri-wound skin. Dry hyperkeratosis present all around the edge of the wound. Edema present on the lower edge. So that breaks up the wound into 3 distinct categories and makes it really easy to understand exactly what you're looking at and describe the wound in a really thorough manner. So you can see the triangle of wound assessment really helps to break up the wound and make it easy for clinicians to understand exactly what they're looking at. Description and documentation is essential, and it helps to prevent issues that could prevent the wound from healing in the future. This assessment needs to include the patient and their family or carer to ensure they understand what to look for as the wound progresses and what is normal and not normal and what to expect in the future. So now we're going to look at acute wounds and their healing, because we're going to be focusing on chronic wounds in future webinars. Here's the definition of an acute wound. An acute wound is any surgical wound that heals by primary intention, or any traumatic or surgical wound that heals by secondary intention and which proceeds through an orderly and timely reparative process that results in sustained restoration of anatomical integrity. To begin, it's important to define exactly what an acute wound is, so there's no confusion when discussing these wounds. Can anyone tell me the difference between a primary and a secondary intention healing? Any ideas? Okay, I'll tell you. A wound healing by primary intention has the edges drawn together with sutures, clips, or wound closure strips, and there's no deficit of skin. For example, a surgical wound, and you can see the wound on the left is a wound healing by primary intention. A wound healing by secondary intention has a deficit of skin and will heal with granulation and epithelialization, for example, a graze or a burn or an ulcer. It's important when you're documenting the wound that you state whether it's a primary intention wound or a secondary intention wound, because this will impact on your dressing selection. Obviously, the dressing here for a primary intention wound is completely different from the one healing by secondary intention. Acute wounds. There are principally two types of acute wounds: traumatic wounds and surgical wounds. A traumatic wound, such as a minor cut or abrasion through to extensive tissue injuries, are caused when a force exceeds the strength of the skin or the underlying supporting tissues. A surgical wound is either incised and sutured or laid open to heal by granulation. The wound breaks the skin integrity and including the epidermis and the dermis. Surgical wounds are classified in relation to the potential for infection in the wound. They are considered to be either clean with no infection, for example, an eye or a joint, clean contaminated with an increased risk of infection, such as a gastrointestinal tract, contaminated where they contain a foreign body or are dirty, or dirty wounds where they have a high risk of infection, such as an anorectal area. And this should be part of the description when documenting the wound in the patient's notes. Primary intention wounds, which are contaminated, dirty or infected, are sometimes left open post-surgery whilst the infection resolves, and then they're sutured closed. This is known as delayed primary intention. Dressing selection should be based upon absorbing wound exudate, supporting hemostasis, and protecting the wound from infection. It's also critical to manage the peri-wound area. Exudate levels can be high during the inflammatory phase, and leakage of corrosive exudate onto the surrounding skin under the dressing can lead to blistering. Looking at hard to heal wounds, they are defined as wounds that are slow progressing through the phases of healing or delayed, interrupted or stalled healing due to underlying health factors that impact on the individual and their wound. A non-healing wound can be suggestive of a chronic infection or a biofilm, provided, of course, that holistic assessment has excluded any other underlying problems such as ischemia. These patients can be non-compliant and often have a very poor quality of life as the results of these slow, smelly healing wounds that are non-healing will leave them feeling isolated and alone. Examples of a chronic non-healing wound are venous ulcers, arterial ulcers, diabetic foot ulcers, and pressure injuries. And I didn't say it, but complications are common. So, managing an acute wound. When you have completed a holistic assessment, it's time to look at the needs of the wound. A wound where there is no deficit of skin will really just need the edges held together by either sutures or wound closure strips. The dressing can be a simple dressing to absorb any ooze and protect the wound while it heals. It's a good idea to make it waterproof to allow the patient to shower. An abrasion, of course, will need some cleaning, and depending on where the abrasion took place and the condition of the patient or resident, they may need an antimicrobial dressing as well as an antibiotic in some instances to reduce the risk of infection. And of course, a tetanus shot. These wounds usually ooze a lot, so it's advisable to apply an absorbent pad to manage the ooze. The deeper the wound, the more absorbency is required. Not all dressings are suitable for all wounds. That may seem obvious, but these days there are so many dressings available that it can be confusing to know which one to use for what. A sloughy wound needs a dressing that will clean it up and remove the slough. An infected wound needs something that will kill the bacteria. Heavily oozing wound needs an absorbent dressing, and a dry wound will need a dressing that adds moisture to the wound. Someone who has a delicate or vulnerable skin will need a dressing that protects the skin. Here are some examples of different types of dressings and their actions. It's a good idea to make sure you have a selection of dressings that each do one of these things, as well as a simple island dressing and wound closure strips for minor wounds. Some of these listed can do more than one thing, such as HydroClean Plus, but I'll come back to that in the next session. So, dressings to clean and debride. HydroClean Plus, as I mentioned, iodine dressings, monofilament pads, and hydrocolloids and hydrogels will all do that to varying degrees. Dressings to kill bacteria. Atrom and AG, silver dressings, iodine dressings, and medicated honey will all do that. Dressings that absorb exudate. Zetivit Plus and Zetivit Plus Silicon Border, a new dressing from Hartmann, plus other super absorbent dressings, foams, gelling fibres, and calcium alginates are all designed to absorb exudate. Dressings that donate fluid. Again, HydroClean Plus will do that, plus hydrocolloids and hydrogels. Dressings that protect the wound edge. Zetivit Plus Silicon Border and other silicon foam dressings, plus Atrom and silicon and wound contact layers all work very well to protect the surrounding skin as they stick right up to the edge of the wound and protect that delicate peri-wound area. Children will often benefit from wound closure strips instead of sutures, particularly if it's in an area not under a lot of tension. Suturing usually requires local anaesthetic and a lot of pain and distress for the patient, whereas wound closure strips are easier to apply and much less traumatic for the patient. I know this from personal experience. When my daughter was 4, at my suggestion, she jumped into our pool backwards and cut her chin badly. She ended up in the emergency department where she screamed the place down, having a local anaesthetic and sutures put in. All the time she was yelling, "My mum made me do it." So wound closure strips would have been a much more preferable option. Now we're going to look at burns management. Really, we're just covering minor burns here. As we've already discussed, Assessment is key to good burns management. The severity of the burn will depend on the size, the depth, the location of the burn, and the age and general health of the victim. If you go to the ANZBAR website, you will get a list of all of the indications to refer on. And these are the types of burns that need to be referred onto a burns unit. Assessment of the burn can be very difficult, even for the most experienced clinicians. This is due to the ongoing impact of the heat of the burn on the body and the tissues, which can change the depth, particularly if good first aid is not applied immediately and the burning has a chance to continue to damage the tissues. The true depth of the burn is not often apparent until after 24 hours after the burn has occurred. Therefore, it's always important to reassess after 24 hours. The immediate response is to stop the burning process by removing the burning agent, any clothing or jewellery, straight away. Hold the burn under cool running water for 20 minutes and then up to 3 hours, but be careful not to cause hypothermia, particularly in children or the elderly. But it's been demonstrated that even up to 3 hours, that will benefit the burn if you are just patient. Do not use ice to cool the burn, as this can cause more burning. Good first aid will have a major impact on the extent and impact of the burn. So, treatment of minor burns. These are generally just a reddened area with no blister or a break in the skin. They can, however, be extremely painful. After applying immediate first aid, the burn will continue to be often very painful and will need protection. Hydrosorb gel sheet relieves the pain in a burn by cooling and soothing the area. It's available with a transparent border to secure the dressing in place for up to 7 days, providing protection and comfort while the burn heals underneath. Superficial dermal burns often have a blister, and this will need protection. Atraumin, Atraumin silicon, and Atraumin AG are all low adherent protective wound contact layers. Atraumin is coated in ointment to prevent the wound sticking to the dressing. Atraumin silicon is coated in silicone and does the same as Atraumin, but can be left on the wound for up to 7 days. They're both mesh dressings, so allow the exudate to pass through into the absorbent dressing on top. Atraumin AG is another option, which also provides antimicrobial protection if you've got concerns around the bacterial burden on the burn. These wound contact layers will need an absorbent dressing over the top, such as Zechavit Plus, or to manage the exudate that comes from the burn. We now have a new dressing called Zechavit Plus Silicone Border that has a silicone wound contact layer for gentle adhesion to the surrounding skin, with a super absorbent pad underneath, which will allow moderate to high levels of exudate to be absorbed into the dressing. Then it's covered by a waterproof backing layer to enable the patient to shower with it. This is definitely an all-in-one dressing, which is great for so many different wounds, including superficial burns. Finally, we're going to take a look at skin tears. Why do they occur? As we age, the undulations at the epidermal-dermal junction flatten out and we lose the anchoring points between the two layers, so the epidermis is free to slip and slide across the dermis. This movement leads to more frequent skin tears in the elderly. In addition, the skin is drier and therefore more brittle and takes longer to regenerate. As these wounds can occur so easily, it's important for those at risk to have an environment that's safe from knocks and sharp edges. Good lighting will reduce the risk of falls. Covers to protect sharp edges from coming in contact with delicate skin. Arm and leg protectors are available for people who like gardening and have cats with sharp claws. Anyone caring for someone with delicate skin should ensure their nails are short and they don't have sharp jewellery on. A study by Carolyn Carville in WA and the Silver Chain Nursing Service showed that twice daily moisturising reduces the risk of skin tears on the arms and lower legs by up to 50%. Senile purpura, or skin discoloration, is a common early warning sign. It's seen on the arms and the lower legs because, of course, they're the ones that are exposed to the sun the most. Ageing skin is also often lacking in vitamin D, collagen and moisture, so is brittle and easily torn. As it's slower to heal, each tear requires protection for longer to ensure that it heals properly. So how do we manage these wounds? First step is to stop the bleeding with gentle pressure to the area and elevation of the limb. If the person is taking anticoagulants, then you may need to use a calcium alginate dressing to help stop the bleeding. It's important that the flap has a clean wound bed to reattach to, so clean the wound well and remove any old blood clots or detached skin from the site. Conduct a thorough assessment to understand any other factors that might impact on the person's ability to heal. Ensure the flap is replaced in an anatomically correct position with a glove finger or a moistened cotton tip. Don't secure with wound closure strips, as these have strong adhesives and can cause further skin damage when removed. When a dressing is applied, always mark the direction to remove it on the outside to ensure you don't lift the flap when you're lifting the dressing. This is not what we like to see. We don't recommend using wound closure strips for this very reason. Where would you start? Now, let's think about the dressings. Apply a dressing that will protect the wound while it's healing, manage the exudate, and not cause any harm to the peri-wound skin on removal. See, I've identified the 3 key needs of somebody with a skin tear. They need protection, they need exudate management, and they don't want any further damage to occur to their delicate skin. Hartmann has a couple of options you can use. Option 1. Placing a low adherent wound contact layer on the wound bed, such as Atrom and silicone, can secure the flap and provide a protective wound contact layer. Cover with an absorbent dressing, such as Zejuvit Plus, to manage the ooze, and secure with a light cohesive bandage, such as Pierhaft. Option 2. Alternatively, you can use the new Zejuvit Plus silicone border to provide an all-in-one protection. And as I mentioned earlier, if you're concerned about any infection, you can always apply an Atrom and AG underneath to protect from infection. If the surrounding skin can't cope with any adhesives, then Zejuvit Plus comes in a non-bordered version as well. Also, it's secured with a light cohesive bandage such as Pierhaft. Some clinicians cover with a light tubular bandage such as CoverFlex Fast over the Pierhaft. This will prevent the patients or elderly residents who might have cognitive issues from fiddling with the dressings and loosening the bandage. So, in summary, we've looked at the skin and wound healing. We've reviewed the importance of assessment and good documentation. Acute wounds are usually able to heal without any complication unlike chronic wounds. Always identify the needs of the wound and select a dressing to suit those needs. When treating burns, even if they're minor, good first aid will make all the difference to the outcome of the burn, and refer on if you're concerned. Skin tears are a common wound that needs protection from a gentle dressing that will do no more harm. And lastly, always remember to look at the whole person before you look at the hole in the person. If you'd like a primary care sample pack, please email primarycare.inquiries@hartman.info. Now, I'm thinking there might be some questions. So, yeah. Thank you.
Danielle, did you want to go first?
No, I've got the questions here. She's going to hand them to me.
Oh, wonderful.
So what is meant by wound edge? Well defined. So it's often difficult to define a wound edge, but more often than not, if you're looking at a wound, you can see where the granulation tissue ends and the epidermal margins start. And that is where you're referring to the wound edge. Sometimes they may be undermined, and therefore it's important to clean out that undermining and ensure that there's no opportunity for bacteria to collect or fluid to collect underneath those areas. So ensure that you identify the wound edge being the edge of the granulation tissue and the start of the epidermis, and around those areas try and keep them clean, and any areas that don't look viable need to be debrided and cleaned away by somebody who has experience at doing that. I hope that answers that question. Diabetic foot ulcers, difficult to remove slough. They are difficult to remove slough, and that's often as a result of the problem of diabetes and the issue itself. These people need to have constant debridement. Often it can be they don't have any sensation, and it can be quite easy for you to get carried away and debride too much, but it's important to gently use something like a hydrogel or an autolytic debrider if you don't have training in sharp wound or conservative sharp wound debridement. Otherwise, they can be sent on to a podiatrist and seen by somebody who's trained in debridement, because that can often be challenging to debride these wounds safely when you're not exactly trained in this area. And but my suggestion would be something like our HydroClean Plus, which adds moisture to the wound, softening that sloughy tissue and keeping it softened for the 3 days in between a dressing change, will help to lift that sloughy tissue. And of course, if you want to know anything more about that, you can use this website to get that information. How do you get rid of biofilm if it inhibits healing? Another challenging question. And there are many papers written about biofilm. This is a ability for the bacteria, if they've been allowed to sit on the wound bed, to communicate with each other and form a coating over the surface of the bacteria to protect them from any antimicrobials or antibiotics. So they can be very difficult to lift off. The only way you can really lift them off is by constant debridement, unfortunately. Some products claim that they can actually disturb or disrupt the biofilm, and there are certainly some that have evidence to support that. But the main way to debride a wound that has biofilm is by constant or to get rid of the biofilm is by constant debridement. So every time you change the dressing, you need to get in there and clean that wound bed as vigorously as you can without causing too much pain to the patient, and that disturbs the biofilm. And if you keep doing that over and over again, gradually you'll keep disturbing the biofilm and lifting it off. I hope that answers that question. What is the best way to manage chronic wounds occurred due to fungal skin infection in the groin and buttocks? the best way would be using an antifungal, I'm thinking, and keeping that area as dry as possible. Really, it's a very challenging area, and I haven't got any simple solutions for that. Unfortunately, it's the moisture in the area and probably the person's skin that has been infected with these fungal in spores, and it can be really difficult to deal with. I haven't got any magic solution for that, unfortunately, except to say that you need to keep it clean and dry and use an antifungal. Dressings for large hematomas. Large hematomas, any sort of foreign body like a hematoma, large collection of blood, needs to be removed. Otherwise, it will be a source of bacteria, and that will lead to an infection. So if you have a large hematoma, that needs to be debrided and removed from the area. I don't know where those are, whether that's a referral onto somebody who can take the person to theatre and remove that hematoma, or whether it's small enough that you can clean away that hematoma with some sort of local anaesthetic. It needs to be removed, and then a good wound contact layer that will protect the wound bed from sticking to an absorbent dressing, and then an absorbent dressing with some pressure over the surface to stop any blood from accumulating again, would be my suggestion. What is the difference between atraumin and atraumin silicon in terms of action? So atraumin is coated in an ointment which prevents the mesh from sticking to the wound and prevents the secondary dressing from sticking to the dressing, as the wound bed as well. The mesh allows for the passage of exudate through there. With the ointment, if you've got a lot of exudate, it will wash off that ointment over a period of time. The reason it's on there is because it's very good for the wound bed and prevents the secondary dressing from sticking. But if you've got a lot of exudate, you need to change the dressing after 3 days. With atraumin silicon, it has a silicon wound contact the coating is silicon, and therefore you can leave it on for up to 7 days. So it's a much longer application, and you can leave the wound alone for that period of time. You can even just change the secondary dressing if it's heavily exuding and just leave the silicon on the surface of the wound. Atraumin silicon would be good for wounds such as skin grafts or donor sites, or where you feel confident of leaving that wound alone for a period of time, whereas atraumin is a more regular dressing change up to 3 days. What is keratosis or hyperkeratosis? Hyperkeratosis is that dried, crusty appearance around the edge of the wound, on that wound that I showed you, where it's very caked. Sometimes the cells that I said shed off as we go about our daily living, they build up on the skin and create these little crusty coatings, which is an opportunity for bacteria to build up underneath there and cause the skin to break down around the edge of the wound. So you often see them associated with people who have venous leg ulcers, and they've been in compression bandages, and therefore, when you change the compression bandage, it's very important to gradually pick off as much of the hyperkeratosis as you can to remove that opportunity for bacteria to collect underneath that, and try and improve the skin integrity around the wound. So hyperkeratosis, that crusty, dried appearance around the edge of that wound, which you need to get rid of by applying either picking away at it gradually and softening it with a moisturiser and washing the surrounding skin very well. In coming webinars, I will be talking about wound hygiene, and this is a new concept that's been recently talked about, where people are keeping the wound clean, removing as I mentioned in an answer to an earlier question, those edges where you don't think that edge is viable and it's just going to sit there, and you've got allow for a buildup of bacteria underneath those edges, keeping those edges clean and enabling the smooth migration of the epithelial cells of the keratinocytes across the new granulation tissue for healing. You don't want to see that the edge creating a little tunneling effect or a little cavity there. So trying to keep that gradual and a smooth migration for the epithelial cells to migrate in. Should a flap be pierced to allow fluid out when replacing the flap? I'm guessing you're talking about a skin flap and in relation to skin tears, and I don't think that if there's an opportunity for the fluid to get out from the side, then no, you shouldn't need to pierce the flap at all. If you feel that there is going to be a buildup of fluid underneath that, then I would try and make the flap so that you can allow for a little bit of an exit point at some stage, because you don't want any fluid building up under the flap. You want to create the cleanest wound bed so the skin flap can reattach itself as well as possible.
Is it blister related?
Blisters. How can we heal a blister? So blisters are a contentious issue in relation to burns, and people talk about blisters as being nature's band-aid, if you like, because they're actually covering the surface of the wound. And so if the fluid is not too much and it's not in an area where there's going to be any tension applied to the blister and the blister will burst, then you're best just to leave it alone. The fluid will be reabsorbed. If you cover it with a protective dressing and leave it alone, the fluid inside will be reabsorbed and there shouldn't be any problem. However, if you have a lot of fluid building up and it's in an area where it's likely to burst, then it's a good idea just to make a tiny little incision at the base of the blister to allow the fluid to escape. And that way it can remain protecting that skin and ensure that the wound is protected underneath. Should blisters be pierced with a sterile needle or drained to cover with an absorbent dressing? Yes, so that would be my advice. Only burst the blister and then only with a tiny little needle or something to relieve that pressure underneath. Otherwise, if there's not a lot of fluid buildup, you can leave it alone. And what absorbs exudate? When you have a lot of fluid, so that product that I talked about, Zecuvit Plus or Zecuvit Plus silicone border, both have a super absorbent polymers inside the dressing, which is similar to what's used in feminine hygiene products and in incontinence products that hold on to large amounts of fluid. So if you need a dressing that's going to manage fluid and hold on to it under compression, or in a situation where you want to prevent that fluid from leaking back onto the wound, a Zecuvit Plus or a Zecuvit Plus silicone border, which has the silicone on the wound contact layer, would be ideal. Saying here, doctors stated we must pop blisters. So that's a contentious issue. There are some people that say that blisters should be burst, and as I said, some blisters, if they're under tension, they should be release the pressure, but not if it can be reabsorbed. So that would be my thoughts on that. Just got a couple, getting a lot of questions. Can a wound be a combination of primary and secondary, an infected, poorly approximated surgical wound? Primary and secondary. Primary really is when the healthy wound edges are brought together and the wound edges are held together and viable. So that is a primary healing wound. With a wound where there's an infection, the edges are breaking down, there's even if it started as a primary wound, you're going to end up leaving that wound, particularly if it's infected, you're going to leave it open to granulate up from the base. So then it becomes a wound that's if it can be eventually, if it's only a minor infection and it can be settled down and they can end up sewing it up or suturing it up, then it can be a delayed primary intention. But if it's granulating from the base up, then it's a secondary intention. Don't ever try closing an infected wound with sutures, because it will just break down again. How to prevent overgrowing of granulation tissue, or hyperkeratosis, which is not hyperkeratosis. Sorry, I was just looking at that other question. Hypergranulation. Hypergranulation is when you see that proud flesh and you see the raised tissue up above the epidermal margins. It's often the result of a higher level of bacteria on the surface of the wound, causing an increase in the exudate, and then that is reabsorbed by the granulation tissue. So the tissue expands up above the edge of the wound. The way to reduce that is by using an antimicrobial dressing. So something like the Atraumin AG, which will kill the bacteria, and then something like a Zechovit Plus will put some pressure on that fluid, on that raised tissue, and flatten it out and get rid of the fluid. And along with the antimicrobial dressing, which will kill the bacteria, which is causing the increase in fluid, the pressure will flatten it out as well. Hypergranulation can also occur as a result of constant rubbing of tubing. So if you've got somebody who has a gastrostomy or some sort of a tubing on a mucous membrane, that can also cause hypergranulation to occur. And then in that instance, you need to remove that tension and protect the area from that. The best way to remove slough and biofilm, so I've already sort of answered that, is by constantly debriding the wound. So using something that will either, you can, if you've got the training to do conservative sharp wound debridement, then do that to remove and lift that sloughy tissue, and that will also remove the biofilm. If you haven't, then I would suggest you use a autolytic debrider, and our Hartmann have one called HydroClean Plus, which I mentioned earlier, and which I will talk further about in another session later on. But it constantly debrides that wound by autolytic debridement, and because it's adding moisture to the wound, it also relieves the pain on the surface of the wound. So it's a really nice dressing for that, but I'll talk more about that next time. Does every burn require hospital transfer for a patient in care, even if minor burn? No. So if it's only a minor burn, you don't need to transfer the patient. And the way you can tell is by putting some pressure with a glove finger in the center of the burn and seeing if the the redness comes back. You know that the capillaries haven't been damaged. So by just gently putting some pressure on the center of the burn is a good way to assess the depth of the burn. And if, of course, there is no pain, you know that it's a full depth burn. All burns that are superficial or not too deep, then the nerve endings are all in a lot of pain and screaming, and the patients are usually in a lot of pain. What was meant by wound contact layer when referring to a dressing? The wound contact layer is actually the layer, the mesh that goes down, and these can be used quite effectively to prevent a secondary absorbent dressing from sticking to the wound. So something like Atraumin silicon, Atraumin AG, they're all wound contact layers. They're just gentle, moist dressings that allow the exudate to pass through, and then the secondary absorbent dressing can go over the top to absorb the exudate. So that's a wound contact layer. Okay, steri-strips. Can we use steri-strips? I heard from my friend, don't use, can they be used for skin tears? I'm thinking, oh, I can't read your writing. Steri-strips are banned from aged care. Yep. So steri-strips are designed to hold skin edges together. So the adhesive has to be really strong. It's designed for being applied under a certain amount of tension. If you're putting it on somebody who's got vulnerable, delicate skin, of course, when you remove it, it's going to cause more damage. I know a lot of people say that as the skin cells shed, they lift up the adhesive and shed the adhesive with the Steri-Strip with the skin cells, but it's still putting the patient or resident at risk of getting further skin tears by applying something with a really strong adhesive. So there's much better dressings out there that all the silicone dressings, our Atraum silicone, our Zechovit Plus silicone border, there's lots of other silicone foam dressings out there, all ideal for skin tears. Much better option than wound closure strips. I'm assuming that the application of Steri-Strips to children only applies to minor cuts and lacerations. Yes, that's right. Just to avoid the use of sutures where possible. If you have a wound that is not over an edge that's going to be under any tension and you just want to secure that, yes. But you can also use it on other minor wounds. Often they're used in other areas if they've got cuts or abrasions that can be where you can bring the skin edges together and it's healing by primary intention. It's an easier option than using sutures and local anaesthetic. Sebaceous cysts. Sebaceous cysts, what is the best type of dressing for a sebaceous cyst? Well, my thoughts for sebaceous cysts would be that they would need to be removed first of all and then sutured, and then you would use some sort or sutured or wound closure strips. Probably sutured though, because they're often on the back or in areas where you're under a bit of tension, and definitely on the back. You would never use wound closure strips on the back because you're putting a lot of tension on the wound. So you would use something that to protect a wound that's healing by primary intention, such as an island dressing that is waterproof. Otherwise, sebaceous cysts, they really need to be removed more often than not. And there's not really a lot you can do with them other than that. How often do we need to review an infected wound? Depends on the patient, really, how severe the infection is and their ability to fight that infection. If you have somebody who's elderly and has other comorbidities, then I would do review every couple of days, maybe. Once you're using antibiotics or an antimicrobial dressing, depending on the level of infection. So yes, I would certainly 24 to 48 hours would be my recommendation, but of course that will depend on the level of infection. Can the Atraum coated in silicone break down the peri-wound area too because it's too moist? No, because it actually doesn't release any silicone or any moisture onto the wound bed. It's just a silicone that is contained on the dressing. So it's not released onto the wound or onto the wound or the peri-wound skin. It is just providing a low adherent wound contact layer, so it doesn't cause any trauma when you put an absorbent secondary dressing over the top. When do you use a compression bandage, especially for ulcers? So in the last of these, this series, we're going to talk about the different types of ulcers and how to deal with arterial and venous ulcers, and not in any great depth about arterial because obviously it's something that mainly needs surgical treatment. But the only ulcer that you would really use compression on is a venous leg ulcer, where you're compressing the wound, compressing the leg to remove the fluid that's built up in the lower leg. They are the ulcers that are best treated with compression bandaging, and really that's what will heal the ulcer. It doesn't really matter what you put on the actual ulcer itself, it's the compression that is going to treat that and resolve that issue. Pressure sores at the sacrum area always have risk to be contaminated from urine and feces. Yes. Can you recommend any dressings or management tips? Really difficult area to dress pressure injuries, and it can be really challenging to know exactly what to put on there. My suggestion, sorry. my suggestion would be that you are applying a dressing that you can change daily, so something that's low cost if it's going to be contaminated on a regular basis, so something that is going to address the needs of the wound depending on what the wound is, and how deep it is. We will it's hard to, it's a whole subject on its own. There's just been some new guidelines released on pressure injury management, and it talks about managing pressure injuries in there, but really all you can do is keep the person off that area, cover it with something that's going to be low cost but effective, so that when you have to change it, you need to change it regularly, every day at least. If they're incontinent. If they're not incontinent, it's a lot easier. If you're putting a square dressing on, put it on in a diamond shape so that the actual, the point of the dressing goes down the natal cleft, if you like, and just sits there nicely. Or you can get some nice shape dressings these days in specifically designed to go on in that area, which can help as well. So either of those would be a good idea. And the other thing which can be helpful is to put a skin protection, either a wipe or something like a hydrocolloid around where you're going to put an adhesive, so that when you're constantly lifting off the dressing and the adhesives, you're not tearing the skin around the pressure injury. Okay, I've got 2, 4, 6 to go, and then I don't know what time it is. It's good to use Gelinet on wounds along with Solugel. Would it impact on wound healing? So, yep, that's a good one. So Gelinet would work in a similar manner to Atraumin, in that it acts as a bit of a scaffolding, I guess, and holds the gel in place so that they don't slip off or get absorbed into the secondary dressing. So that will work well to keep the debriding a wound if you've got a wound that is sloughy and needs debriding. The only comment I would make is that sometimes the granulation tissue can grow up in the open weave of the Gelinet, which can cause issues, and it can become stuck. And they have a lot of paraffin on them, which can block the progress of the wound and the granulation tissue. Our Atraumin has a much finer weave, and the actual instead of being paraffin, it's actually an ointment that is absorbed into the skin and is benefiting the skin, rather than causing it to block the surrounding skin and the granulation tissue on the surface of the wound. That paraffin can just sit on the surface and block it and make it difficult for the new cells to grow up. Okay. I was told by a CNE not to clean a surgical wound or ortho wounds, just apply another clean dressing. Well, that's, if she told you that, that's her prerogative to tell you that. I can't speak on behalf of other people or know what sort of wounds that she was referring to, so can't really comment on that. But from my experience, I think it's always a good idea, particularly if you've got an oozing wound, to clean away the exudate and remove any old exudate and tissue from the surface of the wound and keep it clean. Wound hygiene is what we're talking about here. Ideal dressing for stage 1 pressure injury. I think that really a stage 1 pressure injury, there's no break in the skin, it just needs protection. So you would use one of the 5-layer silicone foam dressings to protect the area and prevent any further damage from pressure in the future and keep them off that. So there's a few on the market, and they would be the best option, I would suggest. Can we use the same dressing after assessing after 24 to 48 hours? No, you should always use a clean, sterile dressing to replace the old one. And can we have a similar option if we don't have access to expensive dressings? A simple option. Yes, so there are many low-cost dressings out there that you can use. Sometimes it's a false economy because you're changing it more often and the person has to come back more often, and it takes you more times to dress the wound because you've got to do it more often. So sometimes it can be a false economy. Last one. Last question. What time is it? Oh, is it? Oh, I'm sorry. Last question.
Last question, we'll just let them know those other ones. Get back to them.
We'll get back to you with the other questions. And last question, when to recommend Prontosan. Prontosan is a wash that will clean the wound bed, so you use that when you're changing the dressing. Always, when you're changing the dressing, look at the old dressing and see if it's coped with the exudate, and then and assess to see if it's the right dressing. So always take a good look at the old dressing when you remove it to really understand whether that was the right dressing for the wound or not. And then you soak Prontosan on the wound for 15 minutes, and that will help to lift that biofilm and bacteria and clean the wound bed. Thank you.